Hello and welcome to Noon Conferences hosted by MRI Online. In response to the changes happening around the world right now and the shutting down of in-person events, we have decided to provide free daily Noon Conferences to all radiologists worldwide. Today we are joined by Dr. Stojanovska. She is an assistant professor of radiology, a board-certified diagnostic radiologist, and a fellowship-trained cardiothoracic radiologist. She holds the position of Director of Cardiovascular MR at the University of Michigan and provides excellence in patients' care through collaboration with scientists, physicians, and technologists. Excellence in teaching from radiology residents from University of Michigan 2 times. A reminder that there will be a time at the end of this hour for a Q&A session. Please use the Q&A feature to ask all of your questions, and we will get to as many as we can before our time is up. That being said, thank you so much for joining us today, Dr. Stojanovska. I will let you take it from here.
Thank you, Ashley. It's really a great pleasure to be here and give noon conferences to all of our radiology trainees and attendings. So my name, as you said, is Jadranka Stojanovska, and I'm assistant professor of radiology at University of Michigan. And today I will cover the basic approach to ischemic and non-ischemic cardiomyopathy. Before I begin with my presentation, I would really like to learn about you. And if you can tell me what countries are you coming from, please share that in the chat option. United States, Spain, Egypt, Saudi Arabia, Turkey, India, Spain. Oh, that's excellent. So we have pretty much from all over the world, which is really an amazing thing to see. So let's begin with our presentation. I have nothing to disclose. And the only abbreviation that I will use throughout my presentation is LG, which stands for late gadolinium enhancement. The objectives that we're going to talk about will be covering ischemic cardiomyopathy, where we know that the culprit of the disease is blockage or occlusion of the coronary arteries, and non-ischemic cardiomyopathy, where we know that the culprit is not the coronary arteries. We're going to talk about when imaging is appropriate to answer the clinical question. And the most important, I would say, role for imaging will be why, which is risk stratification of this patient population. I know this is a very busy flow chart. However, we're going to dissect the whole flow chart as I go throughout my presentation. Mainly what I would like to cover right now is that the first image that we're going to look at will be LG, or late gadolinium, or post-contrast images. And then we're going to look at the cine images to look for qualitative evaluation, which is the wall motion abnormality, look at the morphology of the myocardium, and also have a quantitative assessment such as volume and function. So let's first begin with ischemic heart disease. As we said, the culprit of ischemic heart disease is the blockage or the occlusion of the coronary arteries, which basically triggers the cascade of events, which start with metabolic abnormalities, then go with symptomatology in the patient, which they present with chest pain, and we do see ECG abnormalities. And at this point, we're talking about reversible ischemia or ischemic process, and they go all the way to myocardial necrosis or apoptosis, which is known as infarction. An infarct will be irreversible process, which means that there's nothing that we can do. We can save this myocardium from dying. So what role does imaging play in this patient population? Basically, what we need to decide or define is whether the myocardium is viable versus non-viable. And this can play a huge role as how these patients are going to be treated, whether they're going to get a medical treatment versus a revascularization. And why is that important? Is because revascularization of non-viable myocardium is associated with increased risk compared to medical therapy. So we definitely would not like to revascularize patients whose myocardium is not viable. However, if we do revascularize a viable myocardium, then we know that we're going to improve function in the myocardium. So the first thing, as I said, we're going to look at the LGE images. And the first thing that we're going to say is whether there is a bright signal or LG is positive versus LG is being negative. If LGE is positive, then we know that that myocardium is not viable. So that means that that tissue is infarcted and it's dead. Our role at this point will be to say whether that it's subendocardial involvement or it's a full thickness of the myocardium that is being affected. So the way that we're going to tell that is basically to see whether the myocardium or the bright signal involves 50% of the myocardial thickness or more than 50. So 50 or less means subendocardial, or if it's more than that, will be transmural or will be full thickness. The next step, if the LGE is negative, in that case, we need to make sure we pay a closer attention to the cine images. So at this point, we're going to identify whether the myocardium functions as normal, which means that during contraction, it contracts 50% of its diastolic thickness. What does that mean? That means that if during diastole, the myocardium thickness is 10 millimeter, during systole, it should be 15, and that will be considered as normal. If the myocardium thickens less than 15, but somewhere between 11 and 14, then we talk about hypokinesis. If the myocardium does not thicken at all during systole, which means it stays at 10 millimeter, then we talk about akinesis. And this kinesis will be if the myocardium bulges outside during systole. So it doesn't really follow the myocardial thickening of the other segments. And in that case, we can talk about ischemia. So these are some of the scar scoring system that has been proposed based on the percentage or the involvement of the myocardium that is being affected. So it goes 1 as 0 all the way till 5, which means 100% of myocardial involvement. And here I have 2 cases or examples that I want to show to you what the subendocardial involvement means, which means less than 50% of the full thickness of the myocardium. This is the bright signal that we can see in the mid-interseptal wall. It will be the intralateral wall. And in the second case, we have full thickness or transmural LGE involving the mid-inferior wall. So here's basically what we discussed, that once the LG is negative, that we're gonna go and look at the cines, right? So we're gonna look at qualitatively look into function, the wall motion, right? Whether, as I described before, whether we're gonna identify akinesis, dyskinesis, or hypokinesis. And in this case, we talk about ischemia. So this will not be infarct. Infarct will be if we do see dyskinesis, and in most of the case, these patients will have a positive LGE. Then the second thing will be to look at the morphology, or look at the myocardium and the myocardial wall thickness. This is really important because in chronic infarct, this heart will undergo LV remodeling, which means that the myocardium is going to be very thinned out. Or in some cases, we may identify normal thickness of the myocardium, but that's also a very important finding to have in the body of our report. And then moving on to quantitative assessment will be to quantify the volume and quantify the function. Because if the function is lower and the volume is higher, then we talk about dilated ischemic cardiomyopathy. So let me show you this example. So we have 52-year-old male with chest pain and hyperlipidemia. And if we see, if we look at the LG image, we do not see any bright signal, which means that there's no scar tissue, so there's no infarct. The only diagnosis at this point that we may encounter will be ischemia. So if I play now this particular 2-chamber view cine image, and I need to scroll a little bit through it so you can better appreciate. You see how it's moving. So what we are appreciating right here is that the mid to apical anterior wall, it's akinetic. It's not really moving as it should be, and it's also thinned out in this particular case. So now we know that there's no positive LGE, which means this is ischemia. We do have positive cine 4 akinesis in the LAD territory because it's anterior wall. So what this patient has to do, or what the management is going to be, it's basically revascularization. In this case, percutaneous coronary intervention was done, stent was placed, and I will show you the subsequent image that we did, and you can definitely see that there was a good function. So the function was restored in this particular case, and the wall was completely normal. So this case, it's a case of ischemia where scar is absent. The next case that I'm going to show it to you, it's a 57-year-old male with RCA occlusion on calf. And as we pay attention, we do see transmural LGE that affects the inferior wall. This will be the mid-level. But even if I show you the basal aspect of the left ventricle, the inferior wall of the basal aspect was also affected. So that is telling us that the proximal RCA is being occluded, which means we need to really pay attention to the right ventricular wall. And we can see here positive LGE affecting the free wall of the right ventricle. So we do have a RCA occlusion. And if I play this, this particular cine, we would see hypokinesis basically at the same segments. Move on to the next case. That was not the next case. This is the next case that I want to show it to you. So now the same thing. We're going to look at the LGE sequence, and what do we see? We see transmural LGE, but we also can identify based on the cine that there's a thinning of the wall of the interoceptal wall. In this case, this will be the base. So if we pay closer attention here, we do see that there's an akinesis of the anterior wall. You see how the anterior wall or the interoceptal wall, it's not moving, it's akinetic. So in this case, we talk about talk about LAD infarct, and how do we know that, right? So let's just talk about a little bit of location. How do we define location? So we do use the 16 segment model. It's not the 17 because we don't really account the extreme apex, which is the 17 segment, but we do account for the 16 segments in the heart. And the first thing, if we start from the most inner circle of the bullseye, which will be the apical region, right? In that case, we know that the papillary muscles are not there, right? So the mid cavity level is being defined by the length of the papillary muscles. If we see papillary muscles in our short axis in the left ventricle, we know that we're in the mid cavity level. Everything above will be base, and everything below will be apical region. So the apical region has only 4 segments. And if I can use and then draw that for you, what are those 4 segments, right? So how can we define the anatomy of the left ventricle and define every single segment? The first thing, we need to define where the mid ventricle is, and that can be defined by the length of the papillary muscle. So the first line that I'm showing it here, it goes by the tip of the papillary muscle, and the papillary muscle is the structure that it's outlined, which is the low signal intensity structure. And then I'm going to draw another parallel line, which will be by the distal tip of the papillary muscle, which will be right here. So now we have divide the left ventricle, or the long axis of the left ventricle, to mid cavity. Distal to the papillary muscle will be apical region, and above the papillary muscle will be the base. So now let's move on to the apical region and defining the 4 segments. The first segment that we need to define is the septum, and the septum is between the anterior attachment side of the right ventricle and left ventricle, and from here we're going to do a 1 oblique line. They will go just like this. The second oblique line that we're going to do is between the inferior attachment site between the right ventricle and left ventricle. So again, the second oblique line. So now what we've done, we have defined the septum, which is this segment right here. Above the X line will be the anterior wall, Then we have lateral wall, which is just across the septum. And then we have the inferior wall, which is inferior to the anterior wall. These are the 4 segments that we see them in the apical region. Now, when we move on to the mid cavity and the base, there are 6 segments in each of these regions. How those 6 segments are being defined? Very easy, just placing one horizontal line that will go across the X. So now we have defined the septum to interoseptal wall and inferoseptal wall, and then lateral wall to anterolateral wall and inferolateral wall. So now if we are identifying an abnormality at the base or at the mid cavity, we're going to report as basal interoseptal wall or mid inferolateral wall. So this will be the proper terminology of the segmental anatomy of the left ventricle. So this is another case that I want to show you. It's a RCA infarct because the basal inferior wall has transmural LGE. And this that I want to show you, you can see this kinesis. So look at the inferior wall. It actually bulges out. It actually bulges out during systole. So during systole, if you pay attention, all these other walls are going inwards, whereas the inferior wall is the only one that goes outwards. Okay, moving on. So if the ischemic heart disease is long-standing, in that case, patients will undergo ischemic cardiomyopathy, which means that that particular wall may not be moving. The left ventricle will dilate over time. And one of the things that we need to pay attention in these patients will be to identify thrombus or clot. Because if the wall is not moving, there's a higher likelihood of developing clots because there's a blood stasis, right? And in this particular case, we can see that there is a scar tissue in the apex and anterior wall of the left ventricle, and we can see a very low signal or DAR signal linear abnormality, which is adherent to the scar, and we know that that is a thrombus. So why is the presence and the thickness of the scar important, right? Once we see them, what does that mean? So these are like several papers that I'm going to show you and share with you. The first one shows us the prognostic impact of the LGE. Using 195 patients, the top panel, it's MACE, which is a major adverse cardiac events. And the bottom panel is actually telling us about cardiac mortality. So we definitely can see that the presence of LGE has a 8 times higher likelihood of causing sudden cardiac death or MACE in this particular patient population. The second paper from New England Journal of Medicine that I'm going to show it to you, it tells us about the relationship between the extent of scar and number of dysfunctional segments before and after revascularization. So if we pay attention at the scar number 4 and number 5, which means that there is a higher thickness of the scar tissue, right? So will be 75 and 100% of myocardial tissue being affected. We can definitely say that 90% of the segments with scar score of 4 or 5 did not improve after revascularization. However, even if we pay attention, we would see that some normal myocardium, which means doesn't have a scar tissue, but it's ischemic, it does not recover function after revascularization. So the question will be, why is that? Well, this paper actually tells us this little secret is that patients will undergo, even though there's still ischemia, right, which is chronic ischemia, these patients will undergo LV remodeling, and this is indicated by increase of end-systolic volume in this patient population. So why do we need to do this and why this is important? Well, this is one of the newest paper, which is the management paper for patients with ischemic cardiomyopathy, and the time when they will get ICD, right? So that will be for primary prevention of sudden cardiac death. So if the patient is asymptomatic, then the ejection fraction should be 30% or less for pacemaker or ICD to be appropriate. If the patients are symptomatic, then the threshold for left ventricular ejection fraction is 35% or less. However, if the patients have an SVT, then the ejection fraction, if it's 40% or less, then this patient will be candidate for pacemaker or ICD placement. And this is really important because all of our measurements, they have to be accurate because they guide clinical management. So now let's move on to non-ischemic cardiomyopathy. I will not really talk about, like what is non-ischemic cardiomyopathy, but what I would like you to know is that we're doing imaging, we're doing cardiac MR, which is pretty expensive to risk stratify patients. It's essentially to identify individuals with increased risk for sudden cardiac death because cardiovascular implanted electronic devices, which includes both ICD and pacemakers, will afford optimal protection against sudden cardiac death. So this is really important. So one, which is important, is to identify what type of cardiomyopathy we're dealing with, that I'm going to show you several examples. And number two, to make sure that we include all imaging parameters or findings or variables in our report, they will guide proper clinical management. So we know that non-ischemic cardiomyopathy can be primary and secondary, and I do have examples of most of these cases. So practical approach, right? The first thing that we're going to do is to look at the pattern of LGE, right? Of course, here will be positive, and the pattern for non-ischemic can tell us if we're dealing with infiltrative heart disease, such as amyloidosis or sarcoidosis, as this basically two cases that I have shown examples here, or we're talking about HCM or hypertrophic cardiomyopathy, or we're talking about myocarditis, right? So that's the first thing. What we're going to identify will be the type of non-ischemic cardiomyopathy. And then number two, why this is very important is to look at the morphology. So look at the myocardium, right? Number one, look if you can see increased trabeculation, that you can identify non-compaction cardiomyopathy. Look if you will identify that the wall is thickened or it's hypertrophied, right? Because in this case, we may be talking about infiltrative disease such as amyloidosis, sarcoidosis, or HCM, which is the hypertrophy, right? Because in patients with hypertrophic cardiomyopathy, the myocytes are hypertrophied. Whereas in patients with amyloidosis, we have increased in extracellular space. The myocytes may remain the same, and that's why we call this thickening and not hypertrophy. And then the second step will be to look at the wall motion. In this case, we're talking about global hypokinesis of the left ventricle or the right ventricle, right? Depends on which ventricle is being affected. And then secondly, look at the volumetric analysis or measurements that we're going to get to talk about the function, right? Whether it's decreased, so dilated cardiomyopathy, involvement of the left ventricle, or the volume of the chambers is being increased, or if the right ventricle is predominantly affected, then ARVC or arrhythmogenic right ventricular cardiomyopathy. So let's start with ARVC first. This is a very interesting case that I would like to share it with you. Is 60-year-old woman with enlarged right side or right heart by echo. And if we pay attention, for some reason, this doesn't really like to move too well, but what we can see is that the right ventricle, it's enormously dilated, right? The right ventricular wall, it's also akinetic, so it's not really moving that well, or severely hypokinetic, and it's not moving so well, and it squishes the left ventricle. We can see definitely flattening of the interventricular septum. So this is predominantly right heart disease. However, if you ask me why this is not pulmonary hypertension and why this is ARVC, and by the way, this was genetically proven case. So one of the reasons that I would like to share with you, and here what I have, it's that there's a LGE present, right? So there's a fibrosis in this particular case that it's involving, and you can see the right ventricle, right, the free wall of the right ventricle, that it's not really moving so well. And how we can distinguish from pulmonary hypertension, it's essentially by looking at the hypertrophy level. Patients with pulmonary hypertension, because of the volume, because of the pressure overload from the pulmonary hypertension, those patients will have right ventricular hypertrophy. Right ventricular hypertrophy is not present in patients with ARVC because that is a disease that affects the right ventricle. Here, what I want to show you, if we pay attention, what it's normal and what it's abnormal wall motion of the right ventricle. So see here, this kinetic free wall, right ventricular free wall on the left-hand side. We also see scalloping of the free wall of the right ventricle, right? So all this like scalloping is not normal, and also some dyskinetic areas. Whereas on the other side, the normal one, you see how smoothly contracts during systole. So this is a normal wall motion. So it's just for you to see, and this patient actually got ICD placed. So what are the criteria, right? So one thing is to identify that there is a RV akinesis, dyskinesis, or dysynchrony. And then number two, which is very important in this patient, is the volume and also the ejection fraction. So the major criteria for placement of ICD will be ejection fraction of 40% or less. And then if the volume of the right ventricle, it's more than 110, which is the normalized by BSA number for male and 100 for women. And just pay attention that we do not look at fat in the myocardium on either CMR nor CT for ARVC. However, the question will be, does ARVC only affect the right ventricle? Well, the answer to this is no. In 56%, it's biventricular. Classic RV only, it's 39%, and 5% is left dominant. So it's really imperative to look at the left and the right ventricles because most commonly both will be affected. And the management, as we discussed in these patients for secondary prevention and for primary prevention, will be ICD placement. And these are some of the high-risk groups that are listed in my slides. So let's move on to cardiac amyloidosis. So if I show you first, let's look at the LGE. What we can see, it's a global subendocardial enhancement, not only of the left ventricle, but also involves the right ventricle as well. And then if I show you the cine here, what are we seeing right here is hypokinesis of the left ventricle and the right ventricle. There's a biatrial dilation. There's also mitral regurgitation and tricuspid regurgitation. And another thing what really catches my eye is the thickening of the myocardium. Pay attention here. I don't say hypertrophy. I say this is left ventricular thickening. There's also thickening of the right ventricle, but another thickening that I would like you to pay attention is the free wall of the right atrium. So if we measure here, the thickening of the free wall of the right atrium is more than 6 millimeters. And let's talk about that as well. If we look at the 4-chamber LGE image, we do see this enhancement not only involving the left ventricle, the right ventricle, but also this free wall of the right atrium as well. So here's some studies that I would like to share with you. The first one includes patients who have undergone biopsy, so 38, smaller sample size, but what it's telling us is that, for example, the negative predictive value of only using ECG is 71%, meaning that for a low voltage EKG or ECG will basically tell us this patient has infiltrative cardiomyopathy or infiltrative heart disease. However, if we pay attention MRI, the negative predictive value of MRI is 90%, which means that the MRI will be more accurate and then the only using ECG or using echo. So here, this paper is also telling us about the prognostic utility of LGE in this patient population. And if we look at the Kaplan-Meier curve, what we're seeing that patients who do have positive LGE, in that case, those patients' prognosis is less favorable than patients who do not present with positive LGE. And here, what I want to show it to you, based on these papers that I have outlined below, is that thickening of the right atrial wall more than 6 millimeter, it's predictive of cardiac amyloidosis. And this is really important because some of these patients present with kidney failure. Sometimes in the past, we were not giving them contrast, and we would say, oh, you know what, we cannot really proceed doing cardiac MRI. Well, that is not the case. Based on these papers, we basically can do non-contrast MRI and look at the free wall of the right atrium. And as I said, the interstitium or the extracellular space expands because of the amyloid deposition, and that's why we're calling thickening, right? So now let's move on to myocarditis. This is a very great case that I would like to show it to you. So let's look at here. LG sequence will be the first one to look at. We have transmural LGE that involves a portion of the inferior wall and infraseptal and infralateral wall. Will be at the level of the base, right? So this is at the tip of the papillary muscles. We don't really see them well. That means we're talking about base. So this will be inferior and infralateral wall, base, inferior and infralateral wall of the left ventricle. So now we know that we have transmural LG. We may think, oh, this is an infarct, right? It's a 42-year-old woman with troponin elevation and history of palpitation. I did say now that it's a woman, right? And it's a young woman, but sometimes we may not know. Even women can present with infarct, right? So, however, the key here is that it's not in coronary artery distribution. It will be very rare, only a portion of the inferior wall to be affected if the entire RCA is being involved, right? So that's why, because this is a non-coronary artery distribution, we know that this is myocarditis. Another key or takeaway finding will be the edema that we are seeing in this patient population, right? So this is an interstitial edema, and that's why we do see this bright signal, because the extracellular space gets bigger, right? So this patient has hypokinesis of the affected area, and we did PET scan just to show the FDG avidity. Okay, so the Lake Lewis criteria, basically what they say is that we need to have 2 out of the 3 positive findings, which means that either the functional abnormality, the LGE positive, or the edema, right? So T2 edema that we're going to see in the affected area. So Lake Lewis criteria, as I mentioned, however, if the patient does not meet the criteria, the Lake Lewis criteria for myocarditis, what do we do, right? So then the consensus is to repeat CMR in 1 to 2 weeks if recent onset and strong clinical suspicion, or if only one criteria is being present, okay? Now let's move on to non-compaction cardiomyopathy. As I have described before, here, for example, we do not start with LG image, right? And the reason is that in this patient, less likely we're going to identify positive LG. Sometimes we don't know whether, that's a blood pool that goes between the trabeculated area, or it's a real LGE. However, the cine images are pretty diagnostic. So as I said, when we look at cine images, we need to look for myocardium, right? So the thickness of the myocardium to identify whether there are trabeculations that are present. And number 2, to look for wall motion abnormality, right? So if we pay attention here, what we're looking at is the hypertrabeculation or increased trabeculation that involves the anterior wall, lateral wall, inferior wall, spares the septum. And if we pay attention on the long axis view, we see that the base is spared. So we have a increased trabeculation that involves the entire left entire left ventricle except the base and the septum, right? And this is a hallmark of non-compaction cardiomyopathy. How do we make this diagnosis based on MR? Is to do the measurements, right? So the measurements that we're going to do is to measure the thickness in the non-compacted area versus compacted area. If this ratio is greater or it's equal to or greater than 2.3, in that case, the patient will meet the criteria for non-compaction. Why we don't use echo for this, right? So we don't use echo. The reason why we don't use echo, because echo does the measurements in end systole, and we do measurements in end diastole. In end diastole, the measurements are more accurate than the end systole. Another reason why is that echo has a limited view or approach to the apex, and this is a disease that basically starts from the apex. So those are the reasons why we would not, why patients are being referred to cardiac MRI, because it does have a great sensitivity of performing these measurements. However, now because we're aware of this entity, I do believe that if you guys practice cardiac MR and perform cardiac MR at your institution, in that particular case, you may encounter many patients who may have increased trabeculation. So that's why this study, MESA study, is really important. So they have identified 323 subjects that do not have any ischemic heart disease or hypertension out of 1,000 patients, and they measured 8 segments. And these are the segments that the measurements are being done at. So we have the mid cavity, as I said, is defined by the length of the papillary muscle, and then the apical region, which is distal or below to the papillary muscles, right? So we have 4 segments here and 4 segments here. What they found, if only one region was measured and taken into account, then 43% out of this normal population met the criteria for non-compaction. And if we include 2 segments, then 6% out of this normal patient population met the criteria for non-compaction. And what is that telling us? That is telling us that we may likely overdiagnose patients, and we don't know what the potential consequences are for this patient. And probably there are different phenotypes. Some that will show trabeculations, but will never develop a disease. And there's so many unknowns, just like this COVID, right? Because for this particular disease, the natural history is lacking. So we don't know. And that's why be careful when you make the diagnosis of non-compaction. I would really recommend to measure 2 or maybe even more than 2 segments that will meet the criteria for non-compaction before making the diagnosis. And another thing is that compacted myocardium should really have an impaired function. So pay attention to those few tips. Now let's move on to hypertrophic cardiomyopathy. This is a very interesting case. We do see asymmetric septal hypertrophy, and you know, that narrows the LVOT area, which causes turbulent flow. With the turbulent flow, we have anterior mitral valve leaflet being sucked anteriorly, and this dark signal that you see it here, it's SAM, is systolic anterior motion. And then because of the anterior leaflet, mitral valve leaflet is being pulled anteriorly, these patients have a mitral regurgitation over time. Their left atrium is going to dilate and dilate. So those are all features that we see in patients with HCM. If we pay attention to LGE sequence, we do see an extensive bright signal, which is the scar tissue. And here you see how I said hypertrophy. It's a septal hypertrophy because of the myocytes are being enlarged. So this particular patient, I didn't mention that the wall measured 28 millimeter, and this patient still got the ICD because of the NSVT that he presented with before. So risk stratification, the established risk factors, if you guys can read from my slide, it says family history of sudden cardiac death. So if somebody presents with this imaging findings, even though they don't meet the criteria by imaging of 30 millimeter or more myocardial thickness, they will still get ICD because of, if they survive from cardiac arrest, unexplained syncope, or family history of sudden cardiac death, right? Why we're doing cardiac MR in these patients and not echo? And if you pay attention from this particular paper, is that the way that the measurements are done on echo and the way that the cuts are being performed, they're so angulated, right? They're not perpendicular to the mitral valve or the interventricular septum as the cardiac MR is doing, right? So the measurements will be more accurate, but the echo underestimates maximal wall thickness in 10%. And in this particular patients where the maximum measurements is the established risk factor, it's really the key. So that is the reason why we're doing cardiac MRI. And this is just the flow chart that is telling us when the patients will reach, as we discussed before, the maximum measurement of 30 millimeter. In that case, they are candidates for ICD placement, right? So the presence of LG does predict increased risk, right, in this patient population. However, up to 80% of HCM patients have LG, so we cannot really place ICD on every patient. There are very conflicting studies. However, there are some randomized trials that are still going on. They're going to provide the correct answers for us and really identify the role of imaging. My last case that I'm going to share with you is dilated cardiomyopathy. This is a very interesting case, and I'll show you the echo first here. You can definitely see that the left ventricle and MR, all chambers are being extremely dilated. You see how there's severe hypokinesis. The ejection fraction was 15%. There's also mitral regurgitation and tricuspid regurgitation because of lack of coaptation of the mitral valve leaflets and the tricuspid valve leaflets. And if we pay attention here on the LGE sequence, we do see that there is a septal or mid-wall LG of the septum, right? So this will be along almost entire septum. And there's a clot here, which was depicted on the echo image, but not on our cine images. So unfortunately, this patient was very young, and then he passed away 2 weeks after cardiac MRI was performed. But let's see some of the papers that talk about the prognosis of dilated cardiomyopathy. So what we can see here is that patients who do present with LG, so we do see mid-wall LG in this particular case, those patients have a poor survival. So this is a very good paper that I'm going to share with you. Is what they say, it's that if patient has no LG present, right, the hazard ratio of dying, or the likelihood is dying, is 1. If the patient do have any type of LGE, then the hazard ratio will be 4 or 4 times higher likelihood of sudden cardiac death in this particular patient. If there's a mid-wall, as you can see here, it's even greater. The subepicardial, it also, the hazard ratio, it's more than 4. So we'll be like, because it's in between, will be somewhere around 6. And then septal, if we pay attention, the patient does have septal LG, then it's also 4, so likelihood of 4. And this is a very nice illustration where it tells us that if the patient only has a septal LG mid-wall, then that it's associated with increased mortality. If it's only free wall being affected, then it carries the same likelihood of sudden cardiac death as any type of LG being present. But if both septal and free wall are being present, that it's associated with the greatest risk for sudden cardiac death. And what is important in this patient population, it's to look for function. If the ejection fraction is 35% or less, in this patient population, the treatment option will be placement of CID or pacemaker or ICDs. So we talked about ischemic cardiomyopathy and non-ischemic cardiomyopathy. We talked about when we need to do imaging, right? So to answer the clinical question and identify the type of cardiomyopathy that the patient has. And then the second role for cardiac MRI is to answer the question why, which means when patients are going to be candidates for ICD placement to prevent them from sudden cardiac death. So with that, I would like to close and I would open for discussion. Thank you.
Thank you very much. Do you want to go ahead and open the Q&A section and you can just read the questions you see fit to
Yes.
answer?
Yes. Okay. So the first one that I have, at the end of the lecture, can you tell us the countries watching the conference? Thanks. Okay, so the first one that I have here, it's Macedonia, Chile. Okay, hold on. Chile. Okay, hold on. Oh, there are some questions here too. They're not only in the QA. So USA, California, India, Syria, Somalia, Muscat, India, Russia, Kenya, Bosnia and Herzegovina, India. Oh, I'm so happy. Uganda, because I'm Macedonian. I'm Macedonian American. So I'm so happy that I can see some people from my part of the world, Puerto Rico, Egypt, Kuwait, basically from everywhere, Yemen, everywhere. Thank you so much, everyone. So let's move on to the questions. How to differentiate between transmural LG in ischemic and non-ischemic cardiomyopathies. So if you paid attention when I was talking about myocarditis, is basically by looking at the coronary artery distribution versus non-coronary artery distribution. And one of the best way, for some reason, the pen did not work, maybe because this is an online version. When I was practicing myself on my own computer, I could do it. And when I give talks at the meetings or at our noon conferences, definitely the pen works. For some reason here it didn't. But if you do the X through the short axis and you divide the myocardium or short axis on 6 segments, then you would know whether the area of LGE it's in a coronary artery distribution versus not. And the second thing is to have T2 weighted image and look for presence of edema versus not. And the reason why I'm stating that is patients with acute ischemic heart disease, they're going to present with cytotoxic edema, which means that we're not going to see any LGE. Basically, it will be dark core. And in patients with chronic infarct, we're not going to see any edema. So those will be the way to distinguish between the two. So another question, can you please help differentiate between constrictive versus restrictive pericarditis? So constrictive pericarditis versus restrictive pericarditis, that's a very good question. And what we do, even though we didn't really touch here the constrictive pattern, we only talked about restrictive, right, which is cardiac amyloidosis, is that restrictive cardiomyopathy basically involves the myocardium. And that is telling us that the myocardium is not contracting well, whereas in constrictive pericardium, it's thickening of the pericardium. So the pericardium does not allow the myocardium to expand, right? So the only way to differentiate between the two will be the real-time imaging. When we perform that, we see whether there is a flattening or there is a septal bounce, which can only be seen during constrictive pericarditis. Okay, so do you do early gadolinium enhancement sequence? Yes and no. Even though I have not really seen a good yield, even if we do early LGE image. And the reason is that we need to allow the gadolinium from the normal myocardium to wash out, which takes up to 5 minutes. And that's why we try to image them after the 5th minute. So we can capture the trapped myocardium within the extracellular space that is enlarged and scarred. So I would suggest to do LG as is. We did try to do early in amyloidosis, but honestly, I have not really seen a big difference between 5 minutes and the 10 minutes LG sequence. Another question, how to differentiate between hibernating and stunned myocardium on MR? That is a great question. So what I would suggest is that stunned myocardium, it's an acute process. Unless the patient has the symptomatology or it has a chest pain right on a spot when you do imaging, there's no way that you're going to diagnose stunned myocardium on MR. Hibernating, however, it's a chronic state, right? It's a chronic condition where there is a functional abnormality, and that is the reason why we can diagnose it on MR, and that is the case that I have shown you. Stunned myocardium is something to think about TIA or, before stroke, right? So with the brain, myocardium really acts very similarly as, as the stroke. So, if for example, the patient does not have the symptoms right away, we're not going to be able to differentiate. So do you do 4-chamber LG differently than short axis LG, or do you combine them in a single sequence in various lyses? I don't understand this question. How would we do it 4-chamber differently than short axis? We do them the same way. The only thing is the time difference, and we change the inversion time, because by the time we are done with the short axis, it takes like 5 minutes, and then we adjust, we do another loop locker to account for the inversion time, and then we use the right inversion time for the next view. Another question is how to differentiate between transmural LG in ischemic. That's something that we answered already. Can you, do you do early, oh, well, I did that, I answered. How do you rate T1 mapping for cardiac amyloidosis in comparison with LG? That's a great question. And I know there's so much out there about T1 mapping, T2 mapping, especially T1 mapping. However, I would really urge you to use T1 mapping if you have established your own normal values on your scanners at your own institution. Even between different scanners and different strength of the scanners and different vendors, the T1 mapping numbers may differ. So we are doing that right now, so we don't really have, I would say, too much of a cases where I can tell you, yes, we have found a great yield in T1 mapping for cardiac amyloidosis. One of the things that we have found that has a great benefit is the strain, but not T1 mapping. However, I would still say is that we are not currently doing it because of the huge variability among different scanners and or different vendors and different strengths. Can you once again show slides of scar burden in ischemic cardiomyopathy? Yes, I can. If I can do that, let me see if I can just scroll through my slides. Yes, and we can go all the way back, and then I'll show you 50% versus a 100% or transmural. So the other question, but before I do that, because it does take a while until I scroll through my slides, actually should be somewhere here. No, should be somewhere here. Okay, here. So here, as you pay attention, this is here subendocardial, and what I usually do is measure the whole thickness of the myocardium, and then also measure the thickness of the scar tissue, right? And if this is less than 50%, then I will call it subendocardium, and if this is more, is you can pay attention here in the inferior wall, predominantly here and even here, right? It's, if we pay attention lower down here, this is 50 or more than 50%, so we'll be near transmural or transmural. Did you, so another question was, do you mention percentage enhancement in HCM in order to help? No, and we do not do that. The reason is that there's no really a good software that it's reliable and it's reproducible. If you have looked at all these softwares for quantitative measurements, what they're telling you is that there are different thresholds, and the numbers are going to be very, very different. What those numbers mean, nobody really knows, and I would not like to confuse anybody. What we have a common consensus between cardiologists and us is to identify the numbers of segments that are being affected by LGE. So for example, I would really calculate the number of the segments. So if we have basal and mid wall, interseptal and infraseptal walls, in those cases, in that case, we have 4 segments, and I will say 4 segments out of 16 or 17 are being affected. So we do not mention any percentage enhancement in HCM. Move on. How to differentiate between stunned and hibernating? Well, we discussed about that. Thanks for presentation. Oh, I don't know. Can you please revise anatomy once, preferably? We don't report this routinely, so we're not so well versed with it. And anatomy in terms of what? If it's for segmental anatomy, as I said, to look at the papillary muscle. The papillary muscle is telling you the mid cavity level. Below the papillary muscle is the apical region. Above is the base, right? So if you do, and if you put an X sign, and X should go defining the septum, right, which is on the left side of the short axis, that will be the septum. Above the septum is the anterior wall. Across the septum is the lateral wall, and below the anterior wall will be the inferior wall. And if you place a horizontal line through this X, right, then you can define the septum to interseptal wall and infraseptal wall, and lateral wall to interlateral and infralateral wall. And that's why we always report that. How to differentiate between transmural LG and ischemic, that's what we said. Oh, I don't know how I went all the way back. And we talked about that. Can you repeat, please, the percentage of transmurality for LG, or it's correct, less than 50% no transmural? Yes, so will be for ischemic cardiomyopathy, I would say 50% or less will be subendocardial, or less than 50% subendocardial, more than 50% will be transmural, and that will be the best way. Why? Because if the patient has a less than 50% or subendocardial scar, meaning that there's more than 50% that is still viable and still can undergo revascularization, so we will salvage the myocardium that it's still viable. Okay, is it possible to see T2 edema in infarcts? That is a great question. However, I said it's not vasogenic edema, okay? So myocarditis presents with vasogenic edema, something that we can see as a bright signal on T2, but but the cytotoxic edema, which is the edema that we see at the initial stage with acute infarction, is something that we're not going to see, okay? And then that was the question. And let's see, am I going all the way till the end? Just want to make sure I answer every single T2 edema. Do you use T1 and T2 mapping for myocarditis in your hospital? As I said, I love T2 mapping, but not for quantitative purposes, but for qualitative purposes, because T2 mapping does not have too much artifact that it's caused by the blood, I would say, motion, so, or the sluggish flow and the trabeculation. So that's why I love this way. I love T2 mapping a little bit better. T1 mapping, we're not using it on a clinical basis yet. As I said, there's so much into it that we want to make sure the numbers that we're going to present are going to be valid. And that's why I said you have to establish normal values. Do you perform the butamin MRI as a protocol for viability? So that will be stressed. We do regadenoson if the question will be ischemic cardiomyopathy, right? If we know that there's a no scar tissue and that there's ischemic pattern, in that case, we will do regadenoson, but we don't really do that routinely. We do, I would say probably, I don't know how many per year, but not as many. In our institution, nuclear cardiology will be the first stress test to be performed, and if the patient are not eligible for nuclear cardiology, then they will come to us. If there are patients with multiple conditions like sarcoidosis and chronic infarcts, would it be difficult to isolate both etiologies without comparison or history or MR? I guess it is, but I honestly have not encountered something like this. So patients that have sarcoidosis and chronic infarcts, I would say that sarcoidosis really can present like anything, including infarction. How will Takotsubo cardiomyopathy look in CMR? That is a great question. And I don't know if you guys do it, scan patients who present with acute chest pain and you do cardiac MR, right? Because you want to make sure that they are hemodynamically stable and they will go straight to cath. So I have seen some Takotsubo cardiomyopathy from my colleagues around the globe. And what we will see is basically apical ballooning. And in amyloidosis, why there's LG? That is a great question. And when we talk about LG being a scar tissue, right, that is in ischemic cardiomyopathy. When we talk about dilated cardiomyopathy, especially cardiac amyloidosis, we do, so let's talk about this way. The gadolinium is extracellular agent. What does it do? It goes into the extracellular space, stays there in a normal myocardium. 70% of the myocardium is basically extracellular space. Will stay there 5 minutes and it will wash out. If there is anything that is going to enlarge extracellular space, like cardiac amyloidosis, so deposition of amyloid, or there is a deposition of inflammation like edema, right, or sarcoidosis, granulomas, all those conditions are going to expand the extracellular space that will trap the gadolinium, and the gadolinium will stay there for a longer time. In patients with ischemic cardiomyopathy, when we talk about dead tissue, that means that's why we have collagen replacement and fibrosis, and the extracellular space, it's abundant. So that is the reason why we see LGE in infiltrative disease as well. So it's all about the extracellular space. Okay, in amyloidosis, the inversion time will be altered. Can the look-locker sequence help? Yes, because you still want to make sure, even though it can be altered, you still want to make sure you identify some area of the myocardium that appear dark, so you can use that as your guidance for the number for the inversion time. What are some of the more common mistakes you see residents making with these topics? Well, this is really a great question, and the mistakes that the residents are making with these topics are basically in the interpretation. So, and to me is one, that the practical approach, that's why I have come up, and as you have seen in all this like flowcharts, is to come up with a very practical approach and very easy way to tell you what are the images that you would look first, and then what are the things that you can identify from cardiac MR. So we teach our residents from day one, and everywhere where I go and speak, either in Michigan or on a national level. And I have gone to Macedonia, Australia, and Bulgaria so far. So those are the places where I have taught, and this will be the way that I will still continue teaching every single resident that the practical approach is very, very important. Any experience of ECV and in cardiomyopathy, as I said, that's something calculated with T1 mapping. That is something that we do not do. Great talk. Can you please revise anatomy? I said that. Dear Dr. J, greetings from Lockdown, UK. Thank you for your presentation and answer to T1 mapping questions. Site specific and experience is valued. Well, thank you so much. I was at Oxford. Yeah, that's another place where I've been to teach. Okay, any other questions? I hope you guys are staying safe out there, and let's see if there are any other questions, because I don't see. It says things from Italy, oh, from Athens, Greece. If you can read one textbook for cardiac MR, which would it be? That it's a great question, and I do not read any textbooks. I will rather share any of my presentations, or there are excellent papers that I have referenced here that you guys can read, and that's all what you need to know. Thanks a lot for the anatomy. Got it. Is there any role of dual energy CT for edema? No, I do not like CT, mainly because there's a radiation. We can do, it's not that I don't like CT, it's just that even though the spatial resolution is great with CT, MR does have some advantages. The tissue characterization with MR, it's really the key. And there's some chat here. Let's see if I can open. Thank you. Nice presentation. May all coronary stenosis, which diagnosed in angiography, undergo to viability MRI? If I understand this question, is MRI is to tell you whether the myocardium is viable versus not. So that will be the question, and the cath will not tell you anything about the myocardium. Cardiac MRI is one of our weakness points. Thank you very much. I do appreciate that, and I agree, is that in most, there are so many institutions that they're not doing cardiac MR, and I do believe that it's a great tool, and if I was presenting this in a very simple way, please let me know, because I want to make sure you guys understand the way that it's presented. Okay, so excellent presentation. I don't see any other. At the end of the lecture, can you tell us the countries watching the conferences I did, is there a predilection for different viruses causing viral myocarditis for specific areas of the myocarditis? Like some viruses have predilection for intraseptal infralateral wall. So 71% of the myocarditis does involve the infralateral wall. I do not know that there is any viral predilection that will go into the, at least not to my knowledge, that there's any virus predilection. However, we do know, and that's statistics that we do know, that 71% of the intralateral wall is being affected. And I think we ran over time, and I don't know where it's Ashley.
Yeah, thank you so much for taking the time and a little extra time to answer some of those questions today, Dr. Stojanovska. We really appreciate it, and we appreciate all of you for being a part of our noon conference and participating in it. A reminder that this conference will be made on demand, made available on demand on mrionline.com within the next 24 hours. Thursday, April 9th at 12 p.m. Eastern Standard Time, Dr. Prachi Agarwal will be with us for a noon conference on chest, COVID-19. Be on the lookout for an email and social announcements with how to register. You can also register on mrionline.com and follow us on social media for updates and reminders. Thank you so much for everyone's time today, and have a great day.
Thank you.